Tone is the resistance of muscles.
Okay.
Tone is the resistance of muscles to stretch, which has two components. There's phasic tone, which is what you're testing when you do a deep tendon reflex. It's the rapid contraction in response to a high intensity stretch. And then there's postural tone, and that's the prolonged contraction of the muscles in response to the low intensity stretch of gravity. And it's when postural is depressed that the trunk and limbs are unable to maintain their position against gravity. And that's what we mean by floppiness. So we're talking about postural tone when we're talking about hypotonia or floppiness. And there are lots of elements that need to be integrated to maintain normal postural tone. So you need an intact central and peripheral nervous system, and you can get floppiness or hypotonia as a symptom of dysfunction along the whole of the neuroaxis, really. So it's quite important to think neuroanatomically when you're trying to decide where the lesion might be. So it could be brain, spinal cord. If we're talking about the central nervous system, or if we're talking about the peripheral nervous system, it can be in the anterior horn cell itself. There can be a problem with the nerve, the neuromuscular junction, or the muscles. And occasionally, very rarely, the problem isn't actually in the nervous system at all, but there's a condition with severe ligamentous laxity. So I think there's some rare cases of things like neonatal Marfan's, where the child is profoundly floppy just because the ligaments are so lax, and the nervous system itself is intact. They're pretty rare. So how do you examine tone? You need to examine the baby in four postures. Supine, we've already seen the baby lying frog-legged. In traction, which is the pull to sit maneuver, in ventral suspension, and in vertical suspension. So it's important to put the baby through all four of these maneuvers if you can. So we mentioned the supine frog-like posture. A normal term baby is very flexed, as you can see from the Dubovitz cartoon. The legs are adducted and near the abdomen and nicely flexed. So you can see how that contrasts to the floppy baby. And then traction response, you have to hold the infant's hands and pull them up to a sitting position. And the term infant should immediately lift their head in line with the body. And when they're sitting, hold their head erect in the midline for a few seconds. But importantly, you should feel them pulling back against you, against your traction. So they flex at the elbow, knee, and ankle in response to your pull. And you can see this baby, there's no counter traction at the elbows at all, and you can't really see the knees, but there's no counter traction at the knees either. This counter traction is only present after about 33 weeks gestation, so a very prem baby won't have a traction response. But by term, the presence of more than minimal head lag or a failure of counter traction is abnormal, and that this is the most sensitive test for hypotonia traction. So ventral suspension, you drape the baby over your palm with your hand under their chest, and a newborn infant should keep their head erect, keep their back straight, and again flex the elbow, hips, knees, and ankle joints. And you can see this baby, who's can't really see, but it's a baby with Downs. You can see that the head's not in line with the back, the elbows, the knees and hips are not flexed, they're just drooping. So the baby tends to hang limply over your hand. So that's ventral suspension. And then in vertical suspension, you hold the baby, place your hands in the axillae, lift up without grasping the thorax, and they should have enough strength and tone in the muscles for the baby to suspend itself vertically without slipping through your hands. And again, they'll hold their head erect in midline with flexion at the knee, hips, and ankles. Whereas the floppy baby, as here, tends to just slip through your hand with the head falling forwards, the legs dangling. So I'm sure you've all felt that before, but it's important to put the baby through those four maneuvers. So what are the causes? It's really helpful. They're very, very broad, and it's very helpful to try and differentiate them into central and peripheral causes early on in your thought process. A priori, central causes are much more common than peripheral causes. So, big series will show, around 3/4 or more children, babies who are floppy, will actually have a central cause. The most common being HIE, or structural brain malformations or bleeds, and then syndromes, genetic syndromes, including Downs and commonly Prader-Willi. Inborn errors are an important cause, although they're numerically much smaller group than the syndromes or the HIE group. And then the smaller group of peripheral nervous system, with between about 15 to 30% of cases of big series of floppy infants. We're thinking, as we mentioned before, about anterior horn cell, nerves, neuromuscular junction, and muscle. And I'll go through all of these, how you decide. So as I mentioned, there's lots of, there's potential for hypotonia to arise from pathology at many levels of the nervous system. So it's really important to have a systematic approach. So I'm just going to shut the door, it's banging. Sorry, it's my dog trying to get in. Oh, he's sorry. Go away. Go away, go away. Sorry about that. My dog's coming to the study. I'll just ignore him. Sorry about that. So it's important to have a systematic approach, and as with everything in medicine, history, and then examination, vital. And I think the more experience you get in medicine or pediatrics, the more you realise how important these sort of basic tenets of clinical medicine are. I'm trying to shut the door again. If you won't come back. So, history. Even a neonate has some history. They've got a prenatal history, as the mum had potential drug or infection exposure. What was the liquor volume like? If the baby's got a neuromuscular reason for their floppiness, then they often don't swallow very well and have polyhydramnios. So polyhydramnios tends to be a little bit of a red flag to there being a peripheral or neuromuscular cause rather than a central cause. Sometimes the mum will be aware that the baby hasn't been kicking very much. Again, that would make you think that the baby's weak and there's a neuromuscular cause. And occasionally babies with weakness have malpresentation. So make sure you get a feel for the prenatal history. And the perinatal history was the fetal distress. Is this a baby who had low APGARs and has HIE? Was it a breech or cervical delivery? And there's been some cervical cord trauma. This was until I moved to London. This was just a theoretical point on this slide that I've been teaching for years. I've never seen a case, and I've seen two at the London. One born while I've been there. One was actually I've just seen in clinic. But spinal cord trauma still happens. Difficult breech deliveries. One of the patients we've had at the Royal London, the mum refused a section, so it was unfortunately an unnecessary breech delivery. But the other case just was a very, very difficult delivery, so it still happens. Spinal cord trauma, unfortunately, is not just a theoretical thing. Postnatal history. So in theory, babies with some of the inborn areas of metabolism won't develop their floppiness until after they start feeding. So it might actually be have normal tone in the first few hours and not develop floppiness until hours after feeding. I have to say I've never seen that, but theoretically. And then family history is really important. So if there a family history within siblings or more extended family of delayed milestones, motor milestones make you think there's a congenital myopathy in the family. An extended history of developmental delay or premature death, wondering about inborn errors. More helpfully, a dominant pedigree of something like myotonic dystrophy. Myotonic dystrophy is always, you don't get de novo mutations, it's always going to be passed on down the family, so there'll always be a family history if you can elicit it. And then we'll look at myotonic dystrophy, and particularly at mitral myopathy, which is in the NTM1 neonatal version is X-linked, and often the mum will be a carrier for that. So there might be a family history of that, or the mum might have some mild signs herself. So this is an X-linked pedigree of a child with X-linked mitral myopathy, NTM1, who, if you take an extended family history, and you might need grandma for this. So the mum, or even grandma, even great-grandma, might know that there was, along the maternal line, there's been a previous male affected with mitral myopathy with some male deaths that potentially were early deaths that potentially were also NTM1. So get a family history. You might find, in an extended family history, that there's an excess of male deaths, and there is an X-linked condition such as NTM1. Consanguinity obviously raises the instance of autosomal recessive disorders, and then I mentioned myotonic dystrophy, where even if they're not aware of it, there always will be affected family members. It's not a condition where you get de novo mutations. We'll look at that in a bit more detail. So the next thing, you've got a prenatal history and a family history. The next thing is to take a history from the mum and possibly examine mum. So mums with acquired autoimmune myasthenia gravis have about a 10% chance of passing on the antibodies transplacentally. So you can get a transient neonatal myasthenia in the infants, in the neonates. And these mums will normally know they've got myasthenia gravis, but I guess it's possible they've got subclinical, but they'll know, and that they'll have fatigability and ptosis, so that is a risk to the neonate. I just mentioned X-linked myotubular myopathy. Occasionally the mums, if they're carriers, will have some mild facial weakness, but much more usefully, or diagnostically, is congenital myotonic dystrophy. Only mums pass this on. As I said, a parent must always be affected. We'll look at it, but you get this is due to a triplet repeat expansion, and the very big expansions that give you a neonatal presentation or a congenital presentation of myotonic dystrophy. They're very big expansions, and they're probably not compatible with sperm longevity, so they're not passed on by dads. Dads can pass on myotonic dystrophy, but they will pass on small repeats and give, the offspring will have a milder form of myotonic dystrophy, potentially not presenting till adulthood. Whereas these congenital, the babies with myotonic dystrophy, it's always the mum. It's always been passed on in the ovum. So these mums will have some signs. They might not know it. They might know they've got myotonic dystrophy, but it's not at all uncommon for a mum to have some mild percussional grip myotonia, some mild facial weakness, and otherwise, be leading an entirely normal life and not be aware that they've got a problem. So it's very easy to test. It's very easy to get a mum to show you, to a grip, to get them to squeeze the hand and release it. You can percuss the thinner eminence with a tendon hammer, but a grip is fine. And facial weakness is again easy to elicit. So you can make a bedside diagnosis of congenital myotonic dystrophy, and it's a relatively common, neonatal peripheral hypotonia cause. So it's well worth looking at mum. It saves you a lot of angst and other investigations if you can, make a bedside diagnosis. So we've got the history. So next is to examine the baby and try and decide whether we think this is most likely to be a central or peripheral cause of floppiness. So obviously you'll do a detailed physical exam. You'll look for dysmorphisms or organomegaly that might make you think of a genetic syndrome or an inborn error. You'll do a detailed neurological examination. Reflexes can be helpful, but they're quite difficult reflexes in small children, so they're not always helpful. Contractures, if the baby's got some fixed contractures, it tends to make you think it's a peripheral problem. They can occur in central problems, but tend to be more likely in a neuromuscular peripheral problem. Always measure the head circumference. That really helps you refine your diagnosis if the head's very big or very small. And then the pattern of weakness, if there's weakness, is helpful. So the weakness, or the presence or absence of weakness, is the most useful distinguishing feature. And what you're looking for is anti-gravity power. So if a baby's got anti-gravity power, that's what we call floppy strong, and that they're much more likely to have a central cause. So the end organ, the nerves and muscles are working, but the signals from the brain or spine are not. So floppy strong, anti-gravity power, you're thinking of central cause. Whereas the babies who've got a peripheral anterior horn cell nerve, neuromuscular junction, muscular cause, the end organ itself is not responding properly, and they're going to be floppy weak. And if you're lucky, well, not lucky, but if you're, diagnostically, if your luck's in, then they won't have anti-gravity power, and that's a really helpful sign. So try and distinguish, whether they're floppy strong or floppy weak. It's not always easy, because sometimes, despite being profoundly weak, babies have a little bit of anti-gravity power, and vice versa. It can be difficult with a profoundly floppy baby, perhaps profound HIE. It can be difficult to see whether they're moving at all. They might be doing very much. But a baby, say with HIE, who has seizures, even if they're profoundly floppy, not really moving at all, when they seize, you'll see then that they've got anti-gravity power. So that will exclude a profound peripheral cause. So floppy strong versus floppy weak, if you can elicit, is the most useful distinguishing sign. Other things that help you localize a lesion. So if you've got a central cause, they might well have a depressed level of consciousness, lethargic, not tracking visually or imitating facial expressions. Axial hypotonia as well tends to go with central causes. So you often see a floppy baby who actually maybe moving quite nicely, and when you examine their limbs, they don't feel particularly floppy, but when you pull them to sit, they have quite profound head lag. So that's what we call axial hypotonia, and that in the absence of limb hypotonia would make you think this is a central cause. Brusque reflexes, fisting of the hands, will make you think of central causes, and obviously things like seizure apneas, things that make you feel that the brain is not behaving normally, will obviously point you towards a central cause. Whereas the peripheral, the neuromuscular causes, they tend to have fewer movements, as we said, or certainly not much in the way of anti-gravity movement. Might have a paucity of facial expression, a poor suck, cry, and respiratory effort, particularly if they're continuing. With HIE, with time, normally the cry and respiratory effort return even if they've been profoundly depressed at birth. Whereas with the child with an ongoing genetic neuromuscular problem, they'll continue to have a poor suck and cry, and might have a low level respiratory need. They might need some high flow or CPAP. As weeks go by, it's just not improving as you'd expect with a central cause. Obviously, if you've got depressed or absent reflexes, that can be helpful. And then the distribution of the weakness, if you've got weakness, we'll look at, but can be very helpful in distinguishing, which peripheral gene this is you should be looking for. Again, just more clues to specific diagnoses: hepatosplenomegaly, if they've got a storage disorder, congenital infection, retinitis pigmentosa, neonatal leukodystrophy, high forehead, wide fontanelle, thinking Zellweger's, congenital cataracts or glaucoma, Lowe syndrome. Some metabolic disorders are said to give abnormal odours. I've not really come across that personally, but I know that obviously maple syrup urine disease and others are meant to have a characteristic odour. And then the boys with Prader-Willi invariably have undescended testes and often hyperpigmentation. We'll look a bit more at Prader-Willi because it's a fairly common diagnosis. It's worth having a good feel for. This is actually, this might be helpful if you're recording it. This is a very detailed slide. I'm not going to go through this in detail, but I just I made this slide the other day because I was for another reason looking at metabolic diseases, and I think the trouble with inborn errors of metabolism is there are so many of them that I think unless you're a metabolic paediatrician, it can be very hard to keep your eye in for them. And I think it's really helpful to, as you come across cases or learn about cases, to think about what the distinguishing features are, to try and get your eye in. So I think particularly, so I made this table the other day. Obviously, it's not not exclusive. It's not exclusive or inclusive of all diseases, but it's some sort of pointers towards conditions such as if you've got a macrocytic anemia. We've had a baby recently who had an MTR deficiency, an enzyme in the methionine pathway, and actually when we look back, she did have she wasn't particularly anemia, but she had quite a high MCV, which we hadn't really paid attention to. So actually was quite a clue in retrospect. So brittle hair and menkies you'll be aware of, but the other things, I think it's really worth. There aren't many conditions that give you macrocephaly, so really measure the head, and then that helps you. If you've got a really big head, it's going to completely refine your diagnostic algorithm. And likewise, microcephaly, is it congenital? Was it there when they were born, or is it acquired? Was the head circumference normal at birth and has become has dropped down the centiles as they've gone through infancy? Again, these really help you narrow down your diagnostic algorithm. So that's much too detailed a table to go through detail, but I think it's worth thinking, getting your eye in for specific markers for inborn errors. So occasionally there'll be both central and peripheral nervous system involved, and actually quite commonly a baby with a motor unit disorder, so a congenital myopathy, for example, will also have HIE. So they'll have poor respiratory effort at birth, perhaps not a brisk enough resuscitation, maybe it were malpresenting and had a difficult delivery. So it's really not uncommon for a baby who's primarily got a genetic lower motor neuron problem to also suffer HIE. And then we know of there are a few disorders which, as well as affecting the peripheral nervous system, affect the central nervous system. So particularly paroxysomal and mitochondrial disorders. Primarily will be CNS disorders, but might well have peripheral involvement, and vice versa. Diseases which are primarily peripheral nervous system might have central involvement. In particular, the congenital muscular dystrophies will have a little look at the muscle brain diseases. So if you look at a big series of floppy neonates, as I mentioned, HIE is, as a singular cause is the biggest cause, but as a group of causes, then the syndromes are the biggest cause. So in particular, Downs, which obviously is easy to pick up, just by the phenotype, but actually Prader-Willi is quite a significant cause as well. And once you've seen Prader-Willi, it's actually quite easy to pick. It's not a difficult one to pick up with clinical observation. Metabolic disorders, they're much rarer, as considering how many, I don't know, 1,000 or whatever, the potential there are within that. Individually, they're obviously super rare. Within the lower motor neuron problems, congenital myopathies and congenital myopathic dystrophy are both the sort of biggest groups. SMA is unusual to present in the neonatal period, but obviously is a fairly big group within the infant period. And then they kind of, muscular dystrophy is pretty rare actually, and then they sort of get rare, and neuropathies are pretty rare. Neuromuscular junction disorders are really rare. And we'll look at those a bit because they're kind of important because they're treatable, but they're quite hard to get your eye in for them because they happen so infrequently. So we'll just go through some of these. So yes, I won't go through HIE. I'm sure you will know about HIE, but if we look at the syndromes, there's that sort of big group, a third of them being a syndrome, Downs and Prader-Willi being the biggest. Then the others you're sort of thinking of are things like Fragile X, the other trisomies, all these deletion syndromes, Wolff-Hirschhorn, Cree-Duchat, these 4P and 5P minus syndromes. I think if you're a geneticist or if you've seen these before, you might pick them at the cot side. They're quite hard to pick up if you're not, seeing these regularly. I think Downs and Prader-Willi are easy. These aren't so easy. So you're almost certainly, if you're suspicious the baby's a bit dysmorphic or, that there might be a syndrome, it's well worth involving your geneticist. And of course, considering early a CGH array or targeted genes, a lot of these will pick up with an array because they're quite big deletions. This is just a kind of a paper that iterates how important the history and examination is in making your diagnosis. In this paper, over 50% of the cases were diagnosed on the history and exam, and then the sort of yield from the complex investigations gets much less. History and exam are going to often give you the major clues. So just look at Prader-Willi because it is, it's 1 in 12 to 15,000 live births. It's relatively common. You will see it if you work on a neonatal unit or spend much time with infants. So these children tend to be low birth weight. They're very floppy. They're sort of these droopy, floppy, rather sleepy babies, but they have anti-gravity movements. They're not weak. They always have feeding difficulties in the neonatal period, and they'll always end up NG fed. I think it'd be vanishingly rare for a child with Prader-Willi not to be NG fed as a neonate. But oddly, they don't have any problem with their respiratory, normally problems with their respiratory function or swallowing their saliva. And that's a very kind of unusual combination. Normally, if you've got a neurological problem that's giving you profound feeding difficulties, you're not going to be swallowing your saliva. You're going to have a lot of secretions. And you'll often have difficulties with a respiratory effort as well. So the babies with a neuromuscular cause of feeding difficulties, the nurses will be suctioning them constantly and they'll need some respiratory support. And likewise, a baby with a CNS cause of feeding difficulties, you'd expect saliva and often respiratory problems as well. So a very unusual combination. So feeding difficulties, needing energy feeding, but no respiratory or saliva control problems is a real red flag for Prader-Willi. They tend to have this very characteristic facial appearance. So they have a high forehead with a narrow bifrontal diameter, dolichocephaly. They're usually very fair. They have these almond-shaped eyes with up slanting papal fissures, and they have downturned corners of the mouth. And the boys have undescended testes. So they are quite easy to pick, actually. Once you've seen one, you'll find it. You'll recognise them again. And of course, you can just send off your DNA for 5Q imprinting defects. You don't need to put them through a whole battery of scans and MRIs and inborn areas of metabolism and arrays. You just go straight for the imprinting defects, and in the vast majority of the cases, you'll pick that diagnosis very quickly and easily. And say it's a COTS-like diagnosis often. Okay, so so that's the central causes. So now we'll move on and look at the peripheral causes. So now we're thinking, we think the baby's weak. They haven't got anti-gravity movements. Is this a problem with the anterior horn cell? Is it a problem with the nerve? Is it a problem with the neuromuscular junction? Is it a problem with the muscle? So anterior horn cell, this by and large means the genetic spinal muscular atrophy. Is occasionally we see a traumatic spinal cord myelopathy following a breech delivery, or occasionally an hypoxic ischemic myelopathy, which will affect the anterior horn cells. But those are rare. These are much more common. When we talk about spinal muscular atrophy, we normally mean the autosomal recessive 5q SMA, which we'll have a look at in a bit more detail because it's fairly common. There are much rarer forms of spinal muscular atrophy, including SMARD1, which we'll look at briefly, and then occasionally Pompe's can look like spinal muscular atrophy. They get the storage material deposited in the anterior horn cells, and that can actually be floppy and look as though they've got SMA. But of course, they have cardiomegaly as well, and usually aren't too difficult to pick. So anterior horn cell, the 5q, also recessive anterior horn cell disease, spinal muscular atrophy type 1. This, again, is a very easy COTS-like diagnosis once you've seen it. So these babies are floppy. In fact, the baby from the beginning, who we looked at the traction response, he has SMA. The pattern of weakness, these babies are weak, and the pattern is a big clue. So it tends to be proximal rather than distal, and legs rather than arms. So their hips are going to be the weakest muscles. They won't really have much movement at all at the hips. They might wiggle their feet a bit. You have a bit of distal movement, but really nothing proximally. And then the legs are weaker than the arms. And the arms, again, they're probably about having movement to the shoulder. They might have a little bit at the elbows and hands. So legs worse than arms, proximal worse than distal. They never have reflexes. A type 1 SMA baby absolutely never have reflexes. So if you get reflexes, it's not going to be type 1 SMA. They usually have feeding difficulties. About a third will have tongue circulation. But the real giveaway clues are the fact that the diaphragm, face, and eye muscles are all spared. So these are really alert babies. You can see, with normal eye movements, lovely alert faces, and then this dramatic diaphragmatic breathing. Unfortunately, the videos won't play on this computer, so I've got videos of diaphragmatic breathing. But actually, I can direct you to a good source of where to look at diaphragmatic breathing if you haven't seen it before. But you can see this baby's, it's called a bell-shaped chest. The intercostal muscles are very weak. They're not, the baby's not got a normal intercostal excursion at all. But the diaphragm is working beautifully. So that's why the baby's alive. So they end up with this very alert face, normal eye movements, and this profound diaphragmatic breathing. And once you've seen it, you won't mistake it for anything else. It's a very easy COTS-like diagnosis to make. Yeah, they're just SMA babies, and if I had the videos playing, they would play. But sorry, they won't on this. So SMARD1 is much rarer. This again is another recessive disease. It's another gene, IGH, MBP2. this behaves more like a neuropathy. You know, neuropathy is normally length dependent, so the longest nerves are the weakest, and usually, you know, distal weakness is the problem rather than proximal. So these children have distal weakness. They actually have diaphragmatic failure because they have raised hemidiaphragms here. So they don't really look like SMA. I'm not quite sure why they call it SMARD1, because, you know, they don't look like 5q SMA. It's a different phenotype altogether, but it is another rare anterior horn cell disease. So I mentioned, you know, the neuropathies tend to be length dependent with distal weakness. Anterior horn cells diseases are, you know, I wouldn't say they're common. SMA is relatively common. SMARD's fairly rare. Neuropathies themselves are very rare. So I've actually never seen, other than when I was training, I've not seen any of these. I have seen SMARD1, which can look like a neuropathy, although it is actually an anterior horn cell disease. But the phenotype with distal weakness and if you do nerve conduction studies, the results can look like a neuropathy. These are very rare, so I wouldn't get too sort of hung up on worrying about because you have neuropathies. That you're highly unlikely to see one really, but they should be areflexive. They should have distal weakness. So in terms of neurophysiology and how useful it is, actually usually it's not very useful in floppy infants. The only times it's useful if you suspect a neuropathy, and I've just said that those are super rare, and you know you're seldom going to come across one, or if you suspect a myasthenic syndrome, also very rare, but as we'll look at, you know, potentially treatable. So more important to not miss that. You're not going to get in too much trouble if you look at neuropathy, at least in the early days. So my dog's trying to come in. Sorry. So if you do suspect a neuropathy, then you want to do nerve conduction studies. They're fairly easy to interpret, that although they can be difficult in neonates. But you know, if you get slowness of the either motor and or sensory responses, then you suspect a demyelinating neuropathy. If you get low compound muscle action potentials, you're suspecting an axonal neuropathy. As I say, you know, these are very small print, and I very seldom, you know, request nerve conduction studies in a floppy infant. That's very unlikely to be a neuropathy. However, if you think you might have a myasthenic syndrome, then repetitive nerve stimulation or stimulated single fiber EMG are going to be hopefully diagnostic or really help you with the diagnosis. So occasionally you will want to consider doing some rep stim or SF EMG for to exclude myasthenic syndrome. We'll have a little look at those. Yeah, I've got some slides on those now. So I mentioned that mums who have autoimmune myasthenia gravis, in about 10% of cases, can pass on transplacentally their antibodies to their babies, who will then have a transient acquired neonatal myasthenia, which will just last for a few months until the antibodies disappear. So they might need some support with pyristigmine or neostigmine for the first few weeks or months of life, but that goes away and they don't have a long-term problem. And normally that, you'll know the mother's affected. It won't be a difficult diagnosis. Much more difficult are the congenital myasthenic syndromes, and these are genetic. These are not autoimmune acquired conditions. These are genetic. There's at least 30 genes known. Variable age of presentation, but they can present in the neonatal or infant period. If you're lucky, you'll get a history of fatigable weakness. That's obviously quite hard, sign to elicit, or a symptom to elicit in a small child. The weakness can be generalized or localized, but the presence of ptosis and or ophthalmoplegia is helpful. They're quite unusual signs, actually, ptosis and ophthalmoplegia. There aren't many conditions that you get them in. So if you do think a baby's got ptosis or they've got ophthalmoplegia, and we'll look a bit more at that as a sign. Certainly that's when you start thinking, could this be a neuromuscular junction problem or congenital myasthenia? So the babies can have recurrent apneas, recurrent aspiration, keep presenting with recurrent bronchiolitis, and they're the ones to kind of worry about, mainly because these are treatable symptoms. They're not curable conditions, but they can dramatically improve with treatment. So I'll just briefly go through them, because I think because they're treatable, and because they're difficult to get your eye in for, because they're so rare, I think it merits just spending a little bit of time thinking about them, so that at least they're in your mind if you do ever see a child who might have one. So, as I mentioned, 1 in 100,000 prevalence in the UK, and that's with over 30 genes. So individually, these are all super rare. They're all recessive except for slow channel syndrome, which is dominant. So you should get a dominant history of slow channel syndrome. But otherwise, of course, you might not get a history at all with a recessive condition. And we break them down into genes which affect the presynaptic nerve terminal, the synapse, and the postsynaptic muscle membrane. The most common to the problem with the presynaptic group is that you're either not making or not releasing the acetylcholine quanta, and the most common cause of this is the choline acetyltransferase mutations, causing about 8% of congenital myasthenic syndromes. The synaptic group is a failure to break down acetylcholine in the synapse, so you end up with the postsynaptic membrane being bombarded with far too much acetylcholine, and the predominant cause for this is the COL-Q mutations, the problems in the collagen tail of acetylcholinesterase, which breaks down the acetylcholine, and that's about 16%. And then the other 3/4 are all postsynaptic. This is quite complex, but I think it is worth just having a little look at, because as I say, you don't want to miss these if they ever do come your way. So postsynaptically, we look at acetylcholine receptor itself, either slow or fast channel ion disorders, with respect to how the receptors transferring ions, or more commonly the numbers of the acetylcholine receptor itself, and normally that's mutations in the epsilon subunit. That's the most common cause. And then other proteins on the postsynaptic membrane, which are responsible for the structure and stability of particularly of the acetylcholine receptor postsynaptically, and the most common are DOX7 and rapsin. And then there's a whole group of glycosylation defects which are responsible for assembling and positioning the receptor on the motor end plate. And actually these overlap with the congenital muscular dystrophies. So this is very detailed, but I guess if you guys, if you've got this recorded, if you want to look at this slowly, you can. I won't spend too long on it, but if you've got a CHAP mutation, these children present in infancy with episodic apneas. They can have respiratory failure and bulbar weakness, and they occasionally have sudden infant death syndrome. So sudden unexpected death in infancy. These are the sort of group that you worry about if they come in with a near miss cot death. If they're having recurrent apneas and they're not feeding very well and they may be not breathing very well, this is a group to think about. They do improve with age, so if you can get them through the infant period, they get better. Also, they completely get better, but they become less at risk. The COL-Q mutations, a synaptic group who have too much acetylcholine in the synaptic cleft, tend to have just generalized weakness in the infant period. For some reason, their pupils are slow to respond. If you ever see that as a sign, again, they're static, or they tend to improve with time. These are the ones that, because they've got too much acetylcholine already in the synaptic cleft, they actually get worse if you give them pyridostigmine. So this is a bit of a difficult group to rush into trials of treatment, because if you give pyridostigmine to some of these, shut the door again, they can have myasthenic crises. And then the slow channel syndrome, in terms of acetylcholine receptor function, these are the dominant diseases. They tend to have selective weakness of neck, wrist, and finger flexions, quite specific, weakness and wasting. And you hopefully will see that in a parent if you have a look at the parent, that one of them will be affected. Again, the channel opens and closes very slowly with too much acetylcholine around, and they don't respond to pyridostigmine. So again, that's another of the groups you mustn't give pyridostigmine to. Whereas the fast channel syndrome do respond to pyridostigmine. This is pretty small print. Acetylcholine receptor deficiency, particularly the epsilon subunit, this is the most common group. And these have ptosis and very marked ophthalmoplegia. They basically can't move their eyes in any direction. They tend to have bulbar and limb weakness too. Tends to be quite a static condition and often quite mild. And even with treatment, the ophthalmoplegia doesn't improve. So it's a really helpful sign. If you see ophthalmoplegia, there aren't many things that give you ophthalmoplegia. If you see, marked ophthalmoplegia, think about acetylcholine receptor deficiency. And then the other one, in terms of the postsynaptic structure and stability of the acetylcholine receptors, rapsin is the one that is the one that can present in neonates and infants. The babies that present at birth have arthrogryposis, multiplex congenita, recurrent apneas, and crises, and these are the ones that can keep coming in looking like they've got bronchiolitis. They'll have ptosis. They usually have a divergent squint, but no ophthalmoplegia. So they do have eye movements. They're just squinting, at rest. Okay, but I'll move on a bit from that. It is a very small print, but it's also kind of important because they're treatable. They can be fatal if you don't treat them, and some of them, most of them, you just treat the pyristic mean, and then you can add in other drugs as you get your genes back and more information. But these three, Slow-Town syndrome, COL-Q, and DOC7, all get worse as pyristic mean. And actually, you can have a good go at triaging them just by whether they've got ophthalmoplegia. And you can see even in a newborn baby, you can tell whether you can get them to fix and follow on a black or white target. So you can see whether a baby's got ophthalmoplegia from very early on, and that should help direct your thoughts as to what gene this might be. Of course, ultimately, you'll contact Oxford and you'll send off a gene panel probably. But in the meantime, you've got to manage the baby, and you've got to have some awareness. This might be a problem that you need to address. You certainly don't want to be sending them home with a potential congenital myasthenic syndrome. Okay, so they're rare. Myopathies, if you're going to have a peripheral problem, myopathies are going to be much more common, and we're talking about congenital myopathies, congenital muscular dystrophies, and then, as I mentioned before, more commonly, congenital myotonic dystrophy. I'm moving from that. So, trying to work out which of these muscle diseases you might have. If the baby's got facial weakness, they're not going to have SMA. But they might well have congenital myotonic dystrophy. They might have myopathy. If they've got ophthalmoplegia, I just mentioned that myasthenia is one of the main causes. Myopathy and mitochondrial diseases also cause external ophthalmoplegia. In fact, the previous slide actually was to point out that if you've got ongoing need for respiratory support, feeding difficulties, excessive secretions, I mentioned earlier, these make you think that there's a peripheral problem here. And as I mentioned before, it's not at all uncommon for a baby to be with a peripheral neuromuscular problem to be born in poor condition, look like they've got HIE, maybe they even have some markers of HIE, but then perhaps they're cooled, and the other parameters start to look like there's nothing else going for HIE, and then the baby doesn't establish respiration as you'd expect. So these are the ones you want to consider a neuromuscular disorder in. So no other parameters are HIE, perhaps their CFM's normal, they've got liver and renal function is not demonstrating the abnormalities you'd expect in severe HIE. They're still needing some respiratory support, they've got feeding and difficulties in lots of secretions. These are the ones to think about a peripheral neuromuscular problem. So congenital myopathic dystrophy, as I mentioned, the mum is always affected. The mum will have myotonia, the baby won't. They develop myotonia as they get older, but they don't have myotonia in infancy. So EMG isn't going to help you on the baby. Often there'll be premature delivery, reduced fetal movements. The babies tend to have this carp-shaped mouth with an inverted V-shaped upper lip. They nearly always have talipes. The boys have undescended testes. Mum will have this transverse smile, and she's not bearing her eyelashes. With normal facial power, should be able to completely bury her eyelashes. So she doesn't. It's not that obvious from without getting her very eyelashes, but she's clearly weak, and she's got tongue percussion myotonia as well. So that's grip myotonia. As I mentioned, this is a dominant condition, and there aren't de novo mutations. There's always going to be someone else in the family, and often you get these. The problem is anticipation. So the problem is the CTG repeat getting bigger in subsequent generations, and often, certainly if you do neuromuscular clinics or clinics with myotonic families, you'll get 3 generations coming in. So you can see the granddad here has got that typical hatchet face. He's got ptosis, male pattern balding. His daughter, who he's obviously passed on, probably a not particularly big repeat to. I mean, it just there's nothing evidently there. She probably has got some facial weakness, but then the boy has obviously got this inverted upper lip, myopathic faces, so he's got a bigger repeat. So sorry, this is so it's fairly common, 1 in 3,500 birth incidents. It's this unstable CTG repeat on chromosome 19. It actually affects lots of genes. It's not fully understood. Its full effect, but basically all of us have up to 38 CTG repeats. That's normal. Minimally affected people will have 50 to 100. People with classical, so mums of these children are probably going to have between 100 and 500, and then these congenital infants have between 500 and 2,000. There's not an exact correlation. So in fact, the lab won't tell you how many repeats there are when they give you the result. They'll just tell you that it's it's expanded in a pathogenic range. But you know that your severely affected child is going to have in the thousands, as opposed to their parent or grandparent. For some reason, it doesn't seem to contract. It just I think there are maybe some very rare occasions when there's been a contraction, but it seems to expand. The repeat, triple repeat. So you get this. You can be minimally affected, have an onset in adult or childhood, or the congenital form, which is what we're really talking about. But it's easy to diagnose at the bedside. So yeah, that's just a picture of that's the repeats that that the infants get. So the next group, the next most common group, are the congenital myopathies, and these are based on the histological appearance. So deciding whether someone's got a congenital myopathy or congenital muscular dystrophy, the myopathies tend to be very static conditions. They don't usually progress very much, and their CK is usually normal. It might be slightly raised, it's usually normal. Whereas the congenital muscular dystrophies, these are progressive conditions, and the CK is usually very high, it's many thousand. So when you do a CK in a floppy weak infant, you're doing it to exclude the muscular dystrophies. You're not doing it to exclude the myopathies, because it's probably going to be normal, despite the fact they might have a very, very profound weakness. So the muscular dystrophies are quite rare. As I said, the CK's over 1,000 pretty much invariably. There are many, many genes, at least 33, probably more now. These are the sort of muscle-eye brain group. So they often have a very abnormal brain scan as well, with lots of neuronal migration problems. Whereas congenital myopathies, which are much commoner, are again inherited group with structural changes on muscle biopsy, which defines the terminology, their naming. I'll show you. So they use, I said, these are usually static. The CK is usually normal, so I'll move on to the next slide for this. So we have central core, which just means there's this oxidative staining. There's this hole in the muscle fiber that runs the whole length of the muscle fiber. And then mini core, which just means that there's short lengths of holes, so not running the whole length of the fiber. Nemolin, where you get these little red threads, and then myotubular, where you get this nucleus in the center of the muscle fiber, which is they're also called centronuclear. It's the same thing. So this actually is what you see in the fetal myotube. The nuclei are in the center of the fetal myotube, but by term, the nuclei should all be around the edge of the you can see them on the other stain. They should all be, the nuclei should be all be around the edge of the at the subsacral membrane. So it's actually very easy diagnostic histopathology, because if you see these central nuclei, you know that this is myotubular. But once if you do a muscle biopsy and get one of these biopsy phenotypes, the overlap of genes and the number of genes possible is very great. So it doesn't necessarily help you that much, actually, the muscle biopsy. It'll give you a nice histological phenotype. It won't necessarily tell you what the genotype is. And in fact, we tend increasingly to go straight for congenital myopathy gene panels now. Actually, if you think a child's floppy and weak, and this is a high chance this is a congenital myopathy, we tend to go for gene panels rather than doing muscle biopsies, and use muscle biopsy if you then can't, don't get a definite answer from the gene panel. So RYR1 is the most common gene, and nebulin the second most common gene. But there are a lot of genes and increasing numbers that can cause each of those histological phenotypes. And you can look and see. So if you want to look at the neonatal onset congenital myopathies, ACTA1, nebulin, MTM1, the one I mentioned before, the X-linked myotubular myopathy, always presents in the neonatal period. But these have big presentations in the recessive ryanodine and recessive mutations. You can get a feel from how they present and when they present as to what the gene might be. But ultimately, a gene panel is not really the most helpful way forward. The X-linked MTM1s that are label a little bit, because talking about the fact that mums, if they're carriers, might have some mild features, and there might be a family history. They actually have quite distinctive features that can help you at the COT side to diagnose them as well. So they're usually very, very weak. These boys, they'll often have reduced fetal movements, polyhydramnios, potentially HIE at birth from their profound weakness. Interestingly, they're very big babies. They have big heads, but you also have big long bodies. They tend to have long fingers and toes, and the boys, well, they often have cryptorganism understage testes. So if you've got a very floppy, weak boy who's big and got a big head, think MTM1. They also often have external ophthalmoplegia. So they don't all, but the ryanodine receptor ones who can also have myopathy definitely always have external ophthalmoplegia. Some of the X-linked ones do as well. So if you can try and get the baby to follow a target, and they demonstrate vertical and horizontal ophthalmoplegia, you're really refining down your genetic diagnosis. They usually have respiratory failure. This is a very severe disease. Okay, Nemelin, I mentioned that NEB is one of the common congenital myopathy genes and can present in the neonatal period or infancy. Yeah, so probably MTM1 myotubular myopathy and nebulin Nemelin myopathy are probably most common in the neonatal period. And ryanodine receptor myopathy, it's usually a mild dominant condition, but it can be a severe recessive condition. I think I'm coming to the end, actually. So this was just actually this is a slide out of or a table out of a quite a nice paper on approaching the child with developmental impairment for which you can't find a cause, and I thought it was quite a nice sort of algorithm to follow, because I think what we tend to do in with the floppy infant or with any child with developmental impairment is take the history exam and try and identify whether we think there's a clue, as I've tried to sort of point out in the as the talk's gone along, that lets us target our testing. So does it let us go straight for example, Metabolic Dystrophy or straight for Prader-Willi? If that's negative, or you don't get an answer from that, then you're going to run your first line test, and that might mean doing a bit of a metabolic screen or an array. And if you don't get an answer, then you're obviously going to reassess, see is targeted testing again going to be appropriate as time gone on? Is there something more that's coming, something that's appeared now that allows you to do more targeted testing? And then you're kind of looking for genetics, second line tests, and reviewing, watching for emerging features. I thought that was quite a nice, a slide on how to approach, the testing for these kids. So you want to try and decide if they're quite strong. Oops. You want to take history. Someone's moved, I think. Could S. Shamoon mute, because I think there's interference. Yeah, you want to involve genetics. You might want to involve metabolic. If you've got a baby who's obtunded, having seizures, got wrist-tendon reflexes is strong, you're thinking of central cause, and you're probably going to do imaging, and then you're going to be thinking, often about genetic. Are you going to do array? Are you going to do methylation studies for Prader-Willi? Are you going to do gene panels or targeted mutations? And if they're weak and areflexic, got respiratory feeding problems, you're going to think of peripheral problems. CK, do a CK, but it's a tiny percentage that are going to have a raised CK. It's going to be normal. It's not going to help you except to exclude congenital muscular dystrophies. You're going to do mutation analyses, and often that'll be a gene panel now. You might do a muscle biopsy or neurophysiology. So that is the really nice video to watch. The other video I should put on the slide actually is if you go on the RCPCH website, there's a really good teaching tool for I what it's called now, but it's for picking up Duchenne and SMA basically. I try to remember what it's called, but it's a freely available teaching tool which has some really lovely videos of spinal muscular atrophy babies and Duchenne. So so that's a really good source of looking at if you haven't seen SMA. So I have got slides on SMA, but actually I've gone for over an hour already. So I don't know if it might just be better to take questions rather than bore you with more SMA stuff. So is anybody? Sorry, Mike.
Yeah, let's. So thank you very much. Superb talk. So much got-side knowledge. I think let's take some questions if there's any questions from the group. I'll ask a question whilst people are thinking of their questions. So, I mean, people just think of the babies on the neonatal unit that have been tricky and think of questions from that. But you don't, obviously in your examination, you're testing the tendon reflexes, but I noticed that you didn't sort of work that into any of your kind of heuristics. Is it because you find that they're often equivocal, or?
Yeah, I think reflexes are really difficult to elicit actually. I mean, sometimes they aren't, sometimes they're easy, but I've been doing reflexes for a long time and I often can't get them, and I don't read too much into it. Most, in clinic, the older children as well, unless it really helps me, unless I'm thinking this might be SMA or it might be a neuropathy, and the reflexes are, if they're absent, are going to, completely change my my diagnostic, algorithm. I just think they're hard to elicit. You often don't get them, and it's a hard sign. So, and getting a bit hung up on it's not very helpful. And actually, the only absolute in reflexes is if you've got type 1 SMA, you never have them. Anything else goes, really. You can have reflexes despite having a neuromuscular problem, and you can not have reflexes despite having a central problem. Having brisk reflexes, lots of kids, physiologically brisk reflexes are pretty normal. Lots of kids have very brisk reflexes. So, occasionally they're so brisk, you're kind of convinced that there must be, peripheral tract disorder. But to be honest, I think mostly, I think they're just hard. They're hard to get, and they don't necessarily help you. So yeah, I don't work them into my algorithms.
So a question on reflexes actually from Alice. How does the Morrow reflex compare to peripheral reflexes in floppy baby?
Yeah, you know what? One thing I'm not is a neonatologist. So I don't really do Morrow reflexes. You guys probably know much more than I do about Morrow reflexes. Yeah, it's probably quite useful.
It's quite a good way, like you mentioned, seizures is a good way to see anti-gravity. Morrow is quite a good way to see anti-gravity power.
Yeah,
but
no,
no.
I trained in adult medicine before I went into pediatrics, and
Oh,
somehow I did do a bit of neonates, but not very much. So I'm things like, yeah, primitive reflexes. You guys are much better than me at them. Yeah, sure, you're right. The Morrow reflex is a good way of showing that they have actually got power, that they can, despite the fact they're very floppy, they do demonstrate some anti-gravity. But yeah, I guess I've having done very little proper neonates. It's not something that I work into my examination, but yes, I'm sure it is useful.
the real advantage of reflexes is finding a focal pathology, isn't it? And all the conditions we've discussed are obviously
Yeah,
global. Yeah.
yeah. I mean, I think just generally, I probably find the most useful. I suppose if you think you've got a child who might have Charcot-Marie-Tooth or something in clinic, not getting reflexes is helpful. If they've got brisk reflexes, they're not going to have Charcot-Marie-Tooth. And if you've got really marked parameter signs, if you've got clonus and upgoing planters and very brisk reflexes, that's really helpful. But I have to say, I don't usually find that helpful, even as a focal sign, really, because often you just don't get the knee jerk on that side, and it's not because it isn't there, you just are not hitting the right spot. Or anyway.
Another question from Himat. Babies born to mums with autoimmune myasthenia, how do we approach that situation given that only 10% will be affected?
Well, if the baby's not got any problem, then don't worry. But if the baby's, floppy and weak and not feeding very well or got respiratory problems, then yeah, they need treating with myostigmine. So
So
it's only going
is
to
there
be the
any sort of
baby.
special birth? I've never encountered this in the sort of antenatal counselling, but is there a special birth plan, or do they
I
try and
think there
deliver?
is actually. I've never seen it either, actually. But yes, I think there is. I think there are. I think it's the sort of thing that the obstetricians will, they'll be alerted to. They'll know that they've got a mum with Mycenia delivering, and they will be, yeah. But I don't think I think it'd be very, very seldom that you'd be presented with this as we didn't know this mum had Mycenia and suddenly she's had a baby, and it's pretty rare. I've never seen it. And as you say, I think they'd normally know that the mum was, there's a myasthenic mum delivering, and everyone would be aware, and then they'd look out. But most of the babies won't have a problem, so it'll only be the ones that are struggling, and then you give them, regular neostigmine or for a few weeks. I presume you test. I presume you look for the antibodies in the neonate as well, but I've never had to do it, so sorry.
I have another question actually about you mentioned feeding difficulties, when and swallowing difficulties. When should you do a bulbar EMG for
Yeah.
say the floppy baby with swallowing difficulties?
Yeah. So bulbar EMG is a very difficult investigation. It's kind of yeah. It's super hard to do. Not many people do them, or do them often enough to probably have a very good hit rate for them. Yeah, I think it's difficult. I mean, is Matthew Pitt still at GS, Mike, or is
He's
he?
retired.
He's
So
retired.
yeah.
Yeah. So Matthew Pitt was the neurophysiologist. I mean, I think certainly when I was kind of training, he was the only dedicated pediatric neurophysiologist in the country. Actually, I think everyone else, was adult and pediatric mixed. I don't know if that's still the case, but so he was probably the person with the most experience of bulbar EMG. And actually, although he would be pretty categorical about whether he thought it was normal or not, he had no idea what the cause was. The children that he diagnosed with abnormal, bulbar EMG, whatever the word for that is, I can't think. We've no idea whether they have an acquired or a genetic condition. So it doesn't really help you to understand the problem anymore. You're going to want to image them anyway. Even if the imaging is normal, that doesn't mean they haven't had a very low resolution brainstem lesion that's affecting their bulbar function. So yeah, I think it's a difficult test. It doesn't really take you much further. You kind of know they've got bulbar problems. Having an abnormal EMG doesn't help you decide whether it's what the cause is. So I don't think it's the most useful investigation in the world. Actually, it doesn't really take you any further. It's very unpleasant, and and quite hard to, for the children to do. So I don't want to sort of put you off doing it, but it's not got. I think probably actually the solution is, if you think it might be indicated, just to speak to the neurophysiologist and ask them what they feel they can offer. In the absence of, I don't know who's taken over from Matthew. I'm sure someone excellent has it. It might be they feel they've got a lot off from doing it. I talk to them. If you think it might be a helpful investigation, I talk to them and ask them if they think it would be helpful, because they'll say, yeah, I can help you here, or they'll say, you know what, this is not going to take you any further. Just manage your problem. In general, I think with infants that they need EMG if there's a suspicion of congenital myasthenia, and of course that might be bulbar. They might have a bulbar problem, although they don't necessarily need bulbar EMG for that. You'd probably be looking at limb or facial EMG to make your myasthenic diagnosis, or help your myasthenic diagnosis. I think that's the only group that really need EMG. Everyone else, it's probably not going to be very helpful. The trouble is, there's very low sensitivity and specificity with EMG. So they'll often come back saying, oh, it's a bit myopathic, they're actually myopathic units, and actually the baby's not remotely myopathic. It doesn't, it doesn't, they're not diagnostic tests in neurophysiology, other than nerve conduction. That's pretty straightforward. If you've got slow nerves, slowly conduction nerves, that's a pretty black and white thing. So I'm not sold on bulbar EMG, and it is a problem because if you have these children and what's wrong with them, but you have to image them, you have to think whether this might be acquired or not. I had a group of children who'd had abnormal bulbar EMG, and I was in Cardiff actually, and I put them into before the 100,000 genome, there was a 1,000 genome pilot. I put them all in actually, and I still haven't had any result back. I'm not sure whether I wondered if they had normal imaging. They clearly had problems with swallowing. And Matthew had identified abnormal bulbar EMG, but I presume nothing came out of the genetic study because I didn't get any results back. So yeah, it's a difficult group. Sorry.
Okay. Question from Faraz. Are there specific mutations in SCS and FCS in congenital myasthenia? Does the genetic report mention if the mutation is fast or slow channel?
Yeah, they'll tell you. Yeah, they're different. They're different genes that cause slow channel syndrome and fast channel syndrome. And yeah, the report will tell you. I mean, I think the Oxford group of the congenital myasthenia group are massively into this. So engage in a dialogue with them. If you think you might have a child with a myasthenic syndrome, they'll be more than happy to be involved in either seeing the child or remotely, helping you manage the problem. So if they come back with a pathogenic mutation, they'll definitely help you interpret it. But they're very rare, so you're highly likely to come across one. It's just I'm kind of partly aware because actually I had a family with epsilon mutations in Cardiff I looked after, but they were already diagnosed. I didn't diagnose them, and I haven't diagnosed any. So I've been a consultant for 16 years. I haven't diagnosed any. So either I'm missing some, or they're just very rare. But that doesn't mean that they aren't going to crop up. And if they are one of the ones that's is at risk of sudden infant death, then obviously you really have to have at least the back of your mind: is this someone we should be thinking about? And EMG is going to be in a good pair of hands. Someone that's used to looking at infants is going to be your most useful test, and certainly. But ptosis and ophthalmoplegia, they're unusual signs. If you see those and there's any suggestion this is fatigable or recurrent, aspirations, bronchiolitis, whatever, they're the ones to think about. With the proviso that they're super rare, so it's hard. I mean, it's partly why I put the slides in, because if you don't know about them, you're not going to think about them, and because you don't see them, you don't learn about them. So I think you just have to have a sort of little niggling concern in the back of your mind that you might be missing one.
Great, thank you. But I think that the take-home condition for me from this talk is Prader-Willi, because it seems like something I'm likely to encounter and might make the diagnosis. Once you've seen it, this sort of sleepy, floppy, fair babies,
it's actually quite an easy, and yeah, it's relatively common. It's one of the ones that you will see. Whereas, I mean, most of the others they're pretty rare. All these other syndromes, you might see, a couple in a lifetime. Whereas you'll probably see, I don't know you'll probably see one a year on a busy neonatal unit. I don't know how many babies they get through, but they certainly get them. If you're an neonatologist, you'll see them.
Okay, thank you very much, Louise. There's no more questions. The next talk, something completely different, at 1 o'clock tomorrow on neurosurgical emergencies, what the paediatrician needs to know about neurosurgical patients in the A&E department. Thanks again, Louise. Brilliant.
Okay, thank you. No worries.
Bye.
Thank you so much.